I'm very pleased to represent my co-authors discussing the mitral valve trials from the Cardiothoracic Surgical Network. The network was formed from the National Heart, Lung, and Blood Institute to study surgical topics and represents some excellent centers that have contributed to patients. Ischemic mitral regurgitation is a disease of the ventricle. As you can see from this cartoon, there are forces that pull the valve in either apically or laterally that results in the two mechanisms of ischemic MR, which include annular dilatation and tethering, particularly of the from the posterior papillary muscle involving both the anterior and posterior leaflets. By definition, the valve itself is not abnormal. Therefore, it relates to both loading conditions as well as chronic ventricular changes. The severe MR trial was developed to examine mitral valve repair versus replacement for severe mitral regurgitation due to ischemic disease. This has been a truly controversial topic. There are no guidelines that suggest one versus another, and the few trials that have been present that have been published have been short-term and few patients involved. Now, there is a preference for repair over replacement, which included my own personal bias. Our belief had been repair is an excellent technique and that it would have a lower mortality than those patients who had mitral valve replacement. The data has been inconclusive. Though there have been studies showing lower mortality, there has been a very high recurrence rate with mitral valve repair. Many of us have thought this was related to the type of repair done, including the material used for the rings. So the basic trade-off, which is more important to long-term survival, mitral valve recurrence versus presumed lower operative mortality. Design was very straightforward. Approximately 250 patients were randomized, and half went to repair and half went to replacement. The decision about repair versus replacement was made prior to the patient having the procedure, but just after sternotomy. The primary endpoint was the degree of left ventricular reverse remodeling, that is LV-SVI, both early on and at 12 months. It was powered 90% to detect an improvement from repair to replacement. Secondary endpoints were mortality, recurrent MR, MACE, serious adverse events, and quality of life. In addition, all patients received the appropriate coronary bypass grafts that they needed. We found, in fact, that both modalities, repair and replacement, improved ventricular size over baseline. I believe this is a unique finding and demonstrated that both surgical procedures did improve the ventricular size. However, we did note that recurrent MR at 1 year was significant in the repair group. Approximately a third of the patients had at least moderate mitral regurgitation. In fact, very few had severe recurrent MR. The patients who did had a ring dehiscence, but we were disappointed to see this. By definition, the patients could not leave the operating room with significant mitral regurgitation, so this clearly occurred afterwards. In contrast, we were surprised to note that there was no significant difference in mortality between repair and replacement up to a year. The mortalities for both these series are the lowest reported in the literature, with a mortality rate of 1.8% for repair versus 4% for replacement. So this may explain why the mortality was not different. However, in this patient subset, they were essentially the same. We were left after this trial with the belief that though patients did exactly the same with repair or replacement, we were concerned that the repair patients clearly were at a disadvantage to replacement since the mortality was no different and there was a high recurrence rate. We therefore decided to look further to see if what happened to the patients who had repair, and could we predict which ones would recur. Of importance, you should note from this slide that the patients who did best are the patients who had a repair without recurrence. They had the lowest ventricular size compared to either the replacement group or the patients who had a repair and had a recurrence. So we believe there was a value to be able to do a repair that stayed competent, and we were hoping we could figure this out. We looked at 116 patients in the repair group, and 6 patients had replacements in an OR due to uncorrected MR. All the other patients had mild or less mitral regurgitation on postoperative TEE as the patients were leaving the operating room. We found that many of them went on to have moderate MR, but what was important was it did not go from more than moderate to severe. And I think this is a unique finding. We were concerned that if you had moderate at 3 months, you would have severe by 12 months. In fact, that did not happen, though the percentage that went to moderate MR was approaching 40% at a year. The mechanism for the recurrence is tethering, and you can see this in this particular slide. Now, one should make note of this basal aneurysm finding, and this, I don't know if this is an aneurysm on echo or dyskinesis, but we call these all basal aneurysms. And approximately half the patients who had mitral repair had this finding. And this is highly significant because this was very predictive of recurrent MR. The majority of the patients who had this ended up with recurrence. We also did an extensive analysis for MR recurrence, and we found 10 variables that made a difference using ROC methodologies to determine recurrence. And we believe we can come up with a score sheet to determine which patients would recur. And this is what this looked like. In fact, that recurrence is predictable using this recurrence or death is predictable using this model. However, from a pure anatomic standpoint, the one thing that stood out was the presence of a basal aneurysm. I should state that there was no association with ring size. By definition, each patient in the trial had a semi-rigid, complete ring using reduction annuloplasty techniques. None of the patients had procedures on the subvalvular apparatus. As you can see, that there is no difference between recurrent MR versus and no recurrent MR based on ring size. Essentially, the mean ring size was around 28, and the women had a slightly smaller size. But this is certainly what has been discussed in the literature. So in conclusion, in terms of predictions, about 30% of patients had moderate MR at 1 month post-op. So at 24 months, 46% of patients experienced moderate MR. Basal aneurysm is highly predictive of MR recurrence. We now have a model that needs validation but seems to be promising for predicting patients at high risk. And those patients who are at high risk, particularly anatomically, are either better treated with replacement or perhaps further defined more complex repair techniques. We would like to now go on to the patients who have moderate MR. There has been a controversy in the literature in patients who have moderate MR, whether these patients should have a mitral repair or just coronary bypass alone. And this is most of the centers were in equipoise regarding this issue. So a trial was designed where 150 patients were randomized to CABG alone versus CABG plus reduction annuloplasty. Again, we used changes of left ventricular end systolic volume index at 1 year and noted that, in fact, that did not change in the two groups. In addition, we noted that the mortality was no different, 2.7% for the CABG group versus 1.3% for the CABG mitral repair group. And at 12 months, it was 7% for the CABG versus 6.7% for the CABG mitral repair group. One should note, and this I believe is highly important, that adding a mitral repair to a CABG certainly does not increase the mortality. Now, in terms of conduct and length of stay, there were no major differences other than obviously the patients who had the mitral repair had longer cross-clamp times and bypass times. There was a slightly higher length of stay and slightly higher ICU stay in the CABG mitral repair group. There were no major differences in morbidity other than there was a slightly higher incidence of all neurological events, though there was no significant difference in stroke. However, at the end of 12 months, more patients in the CABG alone group had moderate to severe MR than the CABG alone group. And you might expect this because certainly very little had been done to the mitral repair. However, this did not translate to a mortality issue. Bottom line, at 1 year, there was no difference in the degree of reverse remodeling, mortality, MACE, hospital readmission, etc. The CABG and mitral valve repair was associated with more neurological events, but no increased strokes, and indeed had increased cross-clamp, bypass time, and length of stay. At 1 year, there was a much higher degree of moderate and severe MR in a CABG alone group. The bottom line is we believe both these procedures are effective for treating ischemic moderate mitral regurgitation. Longer-term follow-up will be necessary to determine if the persistent MR will make a difference in survival for the patients who had CABG alone. So I think in conclusion, most investigators for the trial would have guessed wrong for both trials. And I think that it's highly important that we do randomized surgical trials, even over topics that we believe they have the answers for. That way we will have truly a learned approach to what to do best for our patients. Thank you.